afternoon, everybody. My name is Vikas. I'm the Regional Digital Health Advisor with UNICEF. And thanks to the organizers, Ashoka University, Koita Centre, and WHO-SEARO for organizing this session. So my panel is right here. Thank you, everybody. And like Girish mentioned, one of the key aspect of AI development and deployment is when we can really measure the outcomes in terms of the clinicians and the clients. Are we reducing their workloads? Are they making better decisions? Are we improving processes? And are we improving self-care at the community level? So with this introduction, I will quickly introduce my panel. Dr. Aparna is the founder and managing trustee of Armman. Armman leverages mobile health technology to create cost-effective, scalable, gender-transformative, non-linear, and systematic solutions to reduce maternal and child mortality and morbidity in India. Dr. Tavpritesh is a professor of computational biology at IIIT Delhi. He's the founding head of the Center for Excellence in Healthcare. He's a physician scientist and an innovator in the area of digital health, AI, and machine learning for healthcare. He's also a faculty in charge for entrepreneurship in addition to the academic responsibilities at IIT Delhi. I'll move on to Miss Ranita. Miss Ranita is a community health officer, the vice president of All India Association of Community Health Officers at Imphal, Manipur. Thank you for coming all the way from Manipur. She has received more than 20 awards at state, national, and international levels. She's just for noting, she's received the Nightingale Award 2019 by the Indian Nursing Council, Ministry of Health and Family Welfare. Dr. Mohammed Ansari, who's the president of All India Association of Community Health Officers and a district program manager. Dr. Sehj Kashyap is the head of product at Clinikk. He's a physician technologist working at the intersection of clinical informatics, healthcare delivery, and emerging markets. He has built Clinikk, which is India's first technology-enabled healthcare system model after Kaiser Permanente. At Clinikk, he leads product development, focusing on clinical decision support tools, care coordination systems, and consumer health platforms. Next is Dr. Priyanka Bajaj. She's the specialist health technology innovations at Path. She supports and advises on technical, clinical, regulatory, and market access aspects of emerging health care technologies. And next we have, last but not least, Dr. Anshul. He is at ICMR. His primary area of focus is evaluation, validation, and responsible implementation of AI-enabled technologies in public health settings. Let me first start with Dr. Aparna. With your work at Armman, I hope the mics are working. With your work at Armman, at the intersection of community and health workers, what has been the experience of you and your team in the use of technology in AI to support community and health workers? And if you could focus especially on some of the ethical and social challenges in the field of AI.
So Armman works in the space of maternal child health, and from the very beginning, we incorporate technology majorly. We call it tech plus touch solutions because we realized very early on that only technology allows us to create cost-effective, scalable solutions. So we work both with women directly in the field. That is, we support women through pregnancy till the child is 1 year of age and now till 5 years. so that, and on the other hand, we also train health workers at every level of the health system. So what we do is that we work at system level problems, because, almost 90% of women deliver in the hospitals, but not matched by equal emphasis on antenatal and infancy care. And we work on two basic systemic problems. One is access to information. If women are not aware, they will not be able to give optimal care and access optimal care for themselves and their children. And the other hand, if the health workers are not trained at every level of the health system, they will not be able to pick up the risk factors in time, manage in time before it's too late, leading to delayed, complicated, irrational referrals to tertiary hospitals. And so we have a bunch of programs on the women's side, that is 𝐴𝐸, our own program, and then 𝐾𝐈, which is a program in collaboration with the Government of India, which are voice-based solutions. So they started off as voice-based solutions, providing preventive care information, because initially around 2013-14 when we started off, women did not have access to smartphones, so it was important to use feature phones that the women had and the health workers had. So 𝐴𝐸 and 𝐾𝐈 have now reached around 71 million women and their children in 28 states of India. We handhold women through the whole stage of pregnancy till the child is 1 year of age with preventive care information. So it's weekly voice calls, timed and targeted to the age of pregnancy and age of the child. And we call it Tech Plus Touch because it's not just enough to just take phone numbers and information. We also have women in the loop. So we enroll women through health workers stationed in the government hospitals, or through ASHA workers, and the RCS database of Government of India. And there's always, a feedback loop in place through a call center that the women can access. And on the other hand, so, it's not enough that we inform women. It's very important to train health workers at every level of the health system. So we have a program for the ASHAs in collaboration with the Government of India, which is called Mobile Academy, which initially again also started off as a voice-based program. So almost 600,000 ASHAs have been trained in this program. It's 4 hours of content, 11 chapters, 4 sections to each chapter, quiz at the end of each section. So it handholds them through a refresher program on what they need to do in the field. And that is the Mobile Academy program with ASHAs. But then we also have a program for the ANMs, the auxiliary nurse midwives, medical officers and specialists. So because it's very important that they are aware of how to pick up risk factors in time, managing time before it's too late. So we've done the entire spectrum of what needs to get done. So we have created protocols for high-risk pregnancy management for every level of the cadre in collaboration with the Government of India. Now it's been implemented in 5 states. We train them face-to-face and also through, a learning management system, which is digital on their smartphones, that actually trains them in all the protocols through, digitized learning management modules. It's got, notifications, simulations, interactive quizzes. So it really takes them through, video-based format and training, so face-to-face and on their LMS. And then we also have an AI-based chatbot. So basically what happens is that when they go into the field and they have any query, the chatbot, which actually learned from the protocol that we created, can answer every query. And there's two-way communication. And then we have, tracking. So all the protocols have been layered on the database of the Government of Telangana, where we work. Is a large-scale implementation in Telangana, where we actually are able to kind of, track what's happening with a pregnant woman. Because the protocols actually go in depth into how the high-risk pregnancy are managed, and we are able to kind of track where the mistake has happened, and we go back and do iterative training. So it's like a loop of closed loop system where women are informed and health workers are trained. Now we use AI at every level of the health system here, because it's not only that we have created this chatbot, which actually handholds the ANMs. But we also use AI for program efficiency. So, because we reach 71 million women, and handhold them, we're able to use the, AI to actually understand which women are likely to drop out of the system and get them back in the system, because large data systems actually help us understand that. Second, we also use AI for understanding when best to reach the women, based on their schedule over time. So in every aspect of the program, we're using AI. We're also looking at risk detection, etc. Now, when we're using AI, what we're understanding is that when you work in India, across the country, there's a whole issue of inequity, right? So we work with the most underprivileged section of society, and we work out of databases. Databases lack data on these, aspects of society, right? So it's very important that when you do not design for inequity from day one, like we do not design for the scheduled caste, scheduled tribe, the migrant communities, the Muslim community, adolescent, communities, what happens is that we widen the inequity. We worsen inequity, right? So that's one important issue to look at, right? You can't force fit AI into every aspect of our programming. It's so important that it's tailored towards the user and also what the program needs, right? So that's a very important thing that we are focusing on, that how can we reduce inequity instead of widening it and widening the bias, right? Even from the medical context, I'm a urogynecologist, see, as some of, as I think one of the speakers mentioned, when you look at every aspect of, the medical field, data exists for men and not for women. It's all exploited to women. So how do we ensure that we do not create our AI-based systems out of data that is already biased from day one, right? That's one thing. Next is the, consenting processes, right? So when we're working at large scale, using data from 71 million women to create efficiency models, have they really consented to it, right? When we are actually enrolling them into these programs, do they really know what it's going to be used for, the data? What is this push and pull between, using, individual rights and, push for public good? So how do we kind of ensure that women understand that? Second, accountability and liability, right? So we have this AI chatbot, like I mentioned, right? The chatbot has been trained in the protocols. It's doing really, really well. Almost 2,000 ANMs are using it. 70% have asked a question. There's 98% satisfaction with the answers being given. 97% accuracy as marked by medical experts. But, there's a whole aspect of safety and risk, right? I mean, who's accountable if there are any problems? We have a human in the loop system so that the answer is always verified. But what if there's a problem that occurs and the answer is wrong and the implementation leads to mortality in the field? Who's accountable? What are the legal frameworks for the same? That's another thing. An important thing also is the fact that the whole issue of over-reliance on AI, right? So we are wanting to build the AI chatbots for ANMs and now ASHAs. What if they only use that as a modality of answering questions in the field? How do we, what about their own agency? And how do we ensure that, it doesn't lead to loss of critical thinking on their part, right? Because you want them to be, using the tool as only a complement to what they already know from what they've learned in the classroom and through their LMS, but not make it their sole source of information, right? So that is another important thing, right? And this is a larger question for the community, right? How are we going to kind of reduce, critical thinking or nuanced understanding of the problem because you're over-reliant on using AI, right? Second thing is that there's a whole gap on governance and regulation, right? Because there's so many AI-based models being developed, but is it standardized? Is there governance in place to ensure that, the evaluation that's happening is thorough, right? Pre-deployment evaluation, post-deployment evaluation, so it's the thoroughness of all of that is a very important ethical question socially. So, and the whole point of inclusivity, as I already covered, right? Inclusivity from the perspective of underprivileged society, but also what we're facing in the field is voice to text, right? So it works in Hindi, but it will not work in other languages. Now, when you're working in Assam, Bodoland, it's very difficult to create AI-based models that will answer questions in the field, right, for the ANM. So how do we ensure that those gaps are filled? And lastly, another important point I want to talk about is that how do we ensure that the evaluation is so standardized that we are ensuring that tested models are going into the field, because there's a whole lot of so many different AI models being implemented, tested, but is it validated? Is it validated for scale? Is it validated in a manner that, it can be scaled up with, systemic support for it, right? I mean, government support for such large scale, deployment of AI, or still remain, in a pilot stage, because we've really not come to a point where we have worked out the governance, gaps and fill them in a manner that's appropriate for scale up of these solutions. Yeah, I think I've covered.
Great. Thank you, Dr. Aparna, for highlighting those key areas around trust, governance, and equity. I'll move next to Dr. Tavpritesh. And Dr. Tavpritesh, with your work, I'm sure you have interacted with multiple AI models coming from outside of India, from other parts of the world. And like Dr. Karthik's presentation showed, there's very little scientific-based studies that are undergoing right now in India and in the region. What are the challenges that you see in when we go for introducing the existing models? And if you could speak more from the technical and operational challenges of using AI.
Thank you, Vikas. I come from IIIT Delhi and work at the intersection of AI and healthcare. We are an academic lab, but also at the same time, we have touch points which work in the hospitals as well as in the public health settings. A couple of large projects that we're working on look at antibiotic resistance in the public health settings, in fact, in collaboration with PATH, ICMR, and Tata 1mg, and other collaborations such as the ones with hospitals like AIIMS and Max, where we build solutions where we can build early warning systems for patients. So with that background, I think it's very right that we don't have frameworks from the Indian settings, and there are operational challenges in the Indian context. And that's partly because we tend to also look at AI from the generative standpoint only. We have only looked at the generative aspects of AI, which are not ready yet for the healthcare settings, other than chatbots, which are still, the efficacy and safety has to be established and before they can be used. But I think a large section of AI models that's currently completely missing the light is where we use AI models as featureizers, right? So to understand, and that's the process of discovery of science. And that's what we do in our lab, essentially, of looking at how can AI be used to understand human physiology or public health systems. I think that's a key gap that we still don't have any operational frameworks for or even models for. The biggest challenges in this space are obviously the lack of data in this aspect. So we don't have data sets which are publicly available. A few data sets that we know, for example, which are publicly available and large, are from Harvard and MIT. It's called the MIMIC database. Many of us would have used here. That's an ICU data set. And that's one of the largest patient data repositories which is openly available. Another one is from Philips EICU, again from the US settings. We don't have any data sets from the Indian settings. We are in the process of changing that with AIIMS New Delhi. We are in the process of releasing publicly available data from the pediatric ICU at AIIMS, which we call the Safe ICU data set. It will be available on AI Kosh as a part of an ICMR funded study. The second is this workflow mismatch. So once we look at models that are already existing in the domain and are created by Western settings, they don't really fit in the workflows, right? I'll use some other example. For example, I have to quote this, so my apologies. So Google's large study on retinopathy, when that was actually tested in the in Thailand settings, actually it failed miserably because although the model had more than 99%, 95% accuracies and sensitivity and specificity, the metrics, it did not fit well with the workflows. Right, it would keep the health worker waiting, and then they could not actually refer it to the next level, and so on. And this was actually also done. This study was done by Google itself to basically say that models may work well in the lab, but they may not work well in the workflows. And now imagine in the Indian settings, we don't really have models that can scale in the workflow settings. And I think that's partly because we don't have organizations which actually lead some of these guidelines in using AI and workflows. Alignment challenges with social goals. The goals that we have for India are not necessarily the same as the goals that we have for the Western settings. And I think that's a key gap because AI is all across the board. It could be used for screening, for diagnosis, for prognosis, and early warning systems. So where do we want to position ourselves as India in the AI space? I think Alpan made a fantastic point about use of AI for early warning systems. And that's one of these lesser explored areas which we need to actually build upon. These are screening tools where we might go wrong sometimes, but they don't have a huge cost associated with it, because an expert is going to evaluate it at the end of the day anyways. I think aligning up goals with what we are trying to do is very important. Finally, I think linking with the program decisions, there's plenty of AI tools that are out there, but are we starting with the end in mind? I think we're going to be talking about this as well later. I think that's what we also need to do from the operational standpoint. From the technical standpoint, one last thing that I would like to mention: we are enamored by foundation models. We also work on foundation models. We are enamored by large language models, but we forget that a lot of smaller models do exist, which actually perform equally well in the healthcare settings. And this is from our own experience in working in across the board settings. I mean, we've worked with ICUs, we've worked with genomics, public health settings, and we typically find that the advantage that you get from using a very large model is just incremental. And that's not because these large models are not good. It's just because we don't have enough data. If you have to train 7 billion parameters, you need a huge amount of data that goes along with these number of size of parameters. So a small model actually works equally well.
Great. Thank you. Thank you, Dr. Tavpritesh. And it's a really important sort of, I think, key thing to keep in mind is keep the end in mind. And we should have that big picture. Next, I'll turn it over to Ms. Ranita. Thank you for coming. And of course, if I can say, you are our frontline warrior, right? At the community level. If you could sort of share with us some key aspects of working at the primary healthcare level, and when we kind of try to overlay technology and AI on top of that primary healthcare system, what are some key aspects, key things that we need to keep in mind from that community health worker perspective, from the community's perspective, and from a frontline provider perspective, and how we can make sure that keeping the end in mind, right? And what key things we should keep in mind while designing and implementing these solutions.
Good afternoon to everyone. Good afternoon, sir. As a frontline worker, as we are working in a rural place, like in the grassroots level. So before the primary health sub-center was now it is converted to Ayushman Bharat Arogya Mandir. So like while working on that time, like some key aspect, what we need to keep in our mind is that as a frontline worker, when the primary health sub-center is upgraded, that the community people, they don't know like what services we are going to provide. So in the first basic thing, what we have to do is that we need a sensitization, involvement of the community people, active participation we required first, so that we will be providing the services to the community. So that is one of the first things we need to do. Second point is that once the community mobilization has done and the community has accepted that the government of India has implemented various programs, various services which we need to provide through the community. So after sensitizing the community people, then the community will have a trust to us, like the services which we are going to carry out. So the first is the trust building, the rapport building with the community people. And nowadays big hospitals are there, so people want to take the services from the higher facility. But in the rural area, what happened, that is a small facilities which we are going to provide the services. Sometimes in the community people mindset, they used to think that this is a very small center, what services we are going to provide, whether it will be benefiting or whether it will not be benefiting. So in that part, whatever services the government of India has implemented, we are going to convert into a action. So what services we are going to provide, that services should be well understood by the community people. So in that part, the trust and the sensitization is very much important, and cooperation and coordination among our team leader is very much needed. Without a team, we cannot work. Well, we cannot be a one-man army, no? So together we need to provide, as everybody knows, ashas are posted in health and wellness center, CHO are posted, not only that, multi-purpose worker. So we need to have a training. We need to have a good skill to provide their service. So the third point is that we need to have a good knowledge and good skill regarding the service which we are going to provide. And next is, regarding the AI, I would like to explain now. The health and wellness center is now implemented to Ayushman Arogya Mandir. So various portals are implemented, like regarding NCDs, and last in one of the speaker they have explained about NICSHE, that NICSHE Mitra, we have TB screening, and another is regarding Anmol apps, like whatever the pregnant women are identified, we have to make an entry to the portal, like how much pregnant women are there, what injection have been given to that pregnant woman. So that AI, so many integrations are also coming out through Government of India. So to handle that portal, we require a skill, we require in-service education, so that we can implement through the community level. So that is also one of the key aspect we need to keep in our mind. And not only that, the human resource, it is very less in the primary healthcare setting. So we have to see how many programs we are going to implement, and what are the services which we are going to provide to the community people. So whether it is balancing or not, the services will be so much service, and the service provider will be very less. So that also we have to see. So my key aspect is, we have to see all round aspect, so that the services which we are implementing in the primary healthcare, is it universally health coverage is implementing or not, or whether it is benefiting or not. That thing we have to keep in our minds, sir.
Thank you. Thank you, Ms. Ranita, for really highlighting on that aspect of the sort of looking at the entire system and not just at an individual intervention. I'll next move on to Dr. Ansari. Hearing from the community perspective, the next level is, the primary healthcare workers, doctors, the district managers. Based, from that sort of lens, from that experience, what are the current sort of opportunities as well as challenges that you see with the technology and with AI coming in and supporting or not supporting? But what are the challenges and how we can plan to address those challenges?
गुड इवनिंग एवरीवन, गुड आफ्टरनून एवरीवन। सबसे पहले तो मैं आपको बताना चाहता हूँ, जो CHOs है वो कम्युनिटी हेल्थ ऑफिसर्स, मिड लेवल हेल्थ प्रोवाइडर के नाम से जाने जाते हैं। उनका जो काम है, सिस्टम डिस्ट्रिक्ट से स्टेट लेवल और स्टेट लेवल टू सेंटर लेवल, और कम्युनिकेशन यानी विलेज लेवल से तो डिस्ट्रिक्ट से डायरेक्टली नेशनल लेवल तक उनका पूरा डाटा जाता है। OPD में जब पेशेंट आता है ना, तो सारा चीज़ें वही देखता है, स्क्रीनिंग पेशेंट की जो भी होता है, तो हर एक का कॉन्टेक्ट ऑनलाइन एंट्री से। OPD पे हम कर रहे हैं तो ऑनलाइन एंट्रीज है, और PP का पेशेंट भी देख रहे हैं तो NCD के एप्लीकेशन पे देख रहे हैं, टेलीकम्युनिकेशन भी कर रहे हैं तो हम लोग डायरेक्टली ऑनलाइन कर रहे हैं, तो हर एक का कॉन्टेक्ट एप्लीकेशन से है। तो हमारे जो काम में एप्लीकेशंस में बहुत सारे सुधार की ज़रूरत है सर। जब तक कि वो सुधार नहीं होगा तो ओरिजिनल डाटा आना मुश्किल है। मैं ग्राउंड रियलिटी की बात कर रहा हूँ। हमारा जो काम है एकदम परफेक्ट काम रहता है। बहुत सारे ऐप्स ऐसे हैं जिसपे हम लोग आज एंट्री करना चाह रहे हैं लेकिन होती नहीं है, तो उसको आपको अपग्रेड करना पड़ेगा। मान लो निक्षा ऐप है, हमने टीबी की एंट्री करनी है, तो उसमें दिन दिन भर चला जाता है, ऐप ओपन नहीं होता है। तो एआई में कैसे बताएंगे आप लोग? हम लोग तो कर लेते हैं ऑफलाइन, लेकिन ऑनलाइन आपको आज की डेट से चाहिए, तो एआई में आना जब भी ज़रूरी होगा जब वो एंट्री ऑनलाइन होगी। विदाउट ऑनलाइन एआई नहीं बता पाएगा ना। तो हर चीज़ में आपको अपग्रेड करने की ज़रूरत है। हर ऐप में, एक ही ऐप नहीं है, बहुत सारे ऐप है। एनसीडी में भी बहुत सारे इश्यूज है। उसमें बीपी अगर गलती से फर्स्ट टाइम बीपी आ गया उसका, हम लोग पेशेंट को एंट्री मार दी हाइपरटेंशन, तो वो डिलीट नहीं होता है। बीपी का ही पेशेंट रहेगा हमेशा ऑनलाइन ऐप में, तो डिलीटिंग ऑप्शन चाहिए। हम लोग उसको लेटा दिए पेशेंट को, दोबारा देखते हैं कि बीपी नॉर्मल है, तो हम उसको कैसे नॉर्मल बताएंगे? तो ऑनलाइन एंट्रीज में ये भी चीज़ अपग्रेड करने की ज़रूरत है, और बहुत सारे सिस्टम आपको चेंज करना पड़ेगा। और हम लोग को सरकार के साथ डायलॉगबाजी भी करनी पड़ेगी। जब तक सरकार हम लोग की सुनेगी नहीं, तो ये सर ऐसे ही चलता रहेगा। मैं आप लोगों के सामने बोल दे रहा हूँ, ये सारी चीज़ें हमको सरकार से डायलॉगबाजी करनी है। लास्ट टाइम हम लोग सरकार से मिले थे, गवर्नमेंट ऑफ इंडिया के उस टाइम एक्स हेल्थ मिनिस्टर मनसुख मंडाविया सर थे। हमने बहुत सारी चीज़ें उनसे बताई थी, उन्होंने सॉल्यूशन निकाला था, काफ़ी लेटर्स भी निकाले थे, एडवाइजरी भी निकाली थी, चेंज आया था। लेकिन इस टाइम हेल्थ मिनिस्टर ऑफ इंडिया थोड़ा चेंज है, और शायद वो बिजी है, उनके पास टाइम नहीं रहता, तो हम लोग का डायलॉगबाजी नहीं हो पा रही है। हम लोग ने बहुत काम किए है, आगे भी काम करना है, लेकिन आपने हमको इनवाइट किया एआई रिलेटेड प्रोग्राम में, तो हमारा फर्ज था आपको ये चीज़ें बताना, क्योंकि ग्राउंड रियलिटी आपको बताना ज़रूरी है। अगर हम आपको ग्राउंड रियलिटी नहीं बताएंगे तो चेंजेस कैसे आएंगे? अभी हमने मान लिया है कि अभी हम अकेले नहीं, आप लोग भी हमारे साथ है, तो उम्मीद करते हैं साथ में मिलकर काम करेंगे, और आप प्रोग्राम करते रहिए, हम लोग आगे, और आप लोगों का सपोर्ट हमेशा देते रहे कि जो ग्राउंड लेवल की रिपोर्ट है वो हम लोग ऐसा डालेंगे कि एआई में आज की डेट के, आज के टाइम के हिसाब से बरोबर आएगा। थैंक यू।
धन्यवाद अंसारी साहब, थैंक यू, थैंक यू फॉर रियली जो जो सच्चाई है, और हमारा जो, I think going back to Dr. Tavpritesh, looking at keeping the end in mind, I think we really need to focus on reducing the workload of those frontline health workers and making sure that technology is helping them in improving their work, their job, making better decisions. उनका काम आसान कैसे कर सकते हैं हम, और AI से और existing technology solutions से. So thank you. I'll next move to Dr. Sehj. Dr. Sehj, you founded Clinikk, and with your current EHR implementation, I think you've supported primary healthcare doctors in more than 32,000 consultations to date. What problems does AI in primary care need to solve, and how do incentives like managed care versus fee for service shape what we prioritize?
Thank you for that question. Hello, everyone. Firstly, I'm very, very cold. So if I chatter in the middle of my answer, just know that that is the reason. Also, I mean, I am a part of a panel of very esteemed guests and organizations, and relatively Clinikk is unknown. So I thought I'd maybe start with a brief introduction of what exactly we're doing. Clinikk is basically a membership-based healthcare system. What that means is that what we offer patients is that for a fixed annual fee, let's say that you can pay monthly, 900 rupees per month, you can have all of your healthcare covered, including hospitalization. What that means is any medicine, any test, any specialist referral, and if you were to hospitalize, all of that is covered under the 900 rupees that you pay us per month. The only catch or the requirement is that you have to come to our primary care first, and then we take care of the rest. So what that means is that the system that we operate is under intense pressure to make sure that that primary care is high quality, is convenient, is trustworthy, and is something that you choose to come to. Because if you didn't, then it would be very easy for you to reject the plan or just go directly to the hospital and make a claim or anything like that. So we operate 12 clinics in Bangalore. We have our own doctors who are employed. And a clinic is about the size of a small 1 BHK apartment, maybe even less than that, where a doctor, a nurse, and a patient care coordinator work. So from the very beginning, we knew that we had to monitor clinical quality at scale. Otherwise, none of this was going to work. So what you asked about, AI has supported over 30,000 plus consultations. I'll tell you why that is even, been a reason to be developed. So I think we all know there is a crisis in quality of primary care. I think audit studies in different states have shown that 60% of all allopathic medicines which are prescribed in the primary care setting are prescribed by people who don't have a formal medical qualification. The average primary care visit, if you go, will not, 1/3 of them, you won't even get a diagnosis. 1/4 of the time, you won't get the right treatment. And if you look at the, qualifications with which MBBS doctors graduate, almost 60% of medical schools have not had a research publication the last decade. And so, what we have is a lot of prescription patterns when you go to a doctor are memorized, are, stuck in time. And even as the science and as the protocols, as the guidelines evolve, improve, bringing that into real practice is very, very difficult. And so to make that a reality, the nice reality we have is that foundation models, AI models have become sophisticated enough to now provide clinical decision support. And so we use AI in many different ways within our healthcare system. But the most sort of important things is actually clinical care quality monitoring at scale. So firstly, our doctors have really responded well to, look, let me do the prescription, let me take care of the patient. But if there's a mistake I've made or there's a safety event which I may have missed, give me an alert. Tell me that there might be something wrong. Or just let me do my job. Let me do the diagnosis. Don't tell me what this patient has. But in case there's something that the case presentation I may be missing, help me expand my differential diagnosis. Let me think of something that I maybe not have thought of. And then finally, I'll give you an example. A patient was 70 years old. They came to our clinic recently. They had some runny nose, and the doctor said, okay, you have a runny nose. Let me give you some, nasal spray for that, Otrivel. It's a very common sort of prescription for runny nose. And the patient walks out. Now, our system, because every single prescription is monitored with sort of a layer of guardianship, notified the quality team that, hey, this patient had elevated blood pressure. And in that state was given Otrivel. Otrivel is a vasoconstrictor. It can potentially put this patient in a hypertensive crisis, and this patient maybe needs to be referred. At scale, we would never be able, that is a job that would never be able to be done at scale, but is now possible with the help of AI. So to give you an example, if we hired a senior clinician to audit prescriptions of our doctors, they would only be able to audit about, let's say, 4 prescriptions of a doctor in a week. And in that week, the doctor would have seen probably around 400 patients. Those 4 prescriptions would have cost us 70 rupees to audit each, whereas the consultation fee is around 350 rupees. With AI, I can audit every single prescription of the doctors at 70 paisa. And that in 12 months will be 7 paisa. And after that will be even less, right? So there's just new possibilities and capacities that this is creating, which allows us to hopefully make care safer. So hopefully, yeah.
Great. Thank you. Of really looking at AI as a tool to sort of, looking at the prescriptions and what is being done at the primary care settings. Next, I'll move to Dr. Anshul. Dr. Anshul, you've worked on diabetic retinopathy screening in the primary healthcare settings. What are some lessons that you're learning at the community, client, patient, and the health worker level in the implementation of AI initiatives?
Well, thank you so much. So my answers will be based upon the practical experience rather than being technical, and our work has been based in PGI. Currently, I'm based at ICMR right now, but our work has been where I was previously, it was in PGI Chandigarh. So we conducted multiple studies over there in community settings and primary healthcare settings. So we have to deal it comprehensively. So first is patient based, you said. Second is healthcare based. We have to take in infrastructure as well while implementing AI as well. So the challenges will come in. I'll take in examples stakeholder wise, and I'll give the example from our practical experiences. That's what we want to discuss right now. So from the patient perspective, if you want to screen a patient, first of all, you have to tell the patient you have to get screened first. Dealing with diabetic retinopathy, which is asymptomatic, getting those patients mobilized to get screening is number one challenge. When you screen the patient, you screen 1,000 patients, for example, and you find, for example, you have to screen you have to refer 70 patients. To refer those 70 patients, you have to counsel them extensively. Otherwise, you'll lose the patient in between. He or she will not reach the health facility where he or she has desired to be to get the treatment. This is number one challenge in case of patients. And awareness of the disease is prime. You have to tell that patient, if you are diabetic, you are prone to get diabetic retinopathy, get yourself screened within a year after your diabetes diagnosis. This is number one challenge and primary. Forget about AI. You have to deal with the precursors of it first. Coming on to the health system challenges, if you talk about infrastructure. So very interestingly, we implemented our studies during COVID time and post-COVID and pre-COVID. So the challenges were very interesting when we deal with the health system. So it was peak June and July. In the month of June and July, we were doing screening at the health and wellness center level. So unfortunately, there were power outages in between. That is quite common. It happens in summers. And all our screening cameras, our tabletop cameras, the charger adapters, everything got damaged with power outages, and patients were standing outside. So that's a practical challenge when you have a diabetic patient who's sitting outside, hot summer days, what to do next. So these are some challenges. And we were talking about AI screening. To run AI, you need to have electricity first, because we were not using portable cameras. Those were tabletop cameras that has to be used within the health and wellness centers. Community screening is something else. You can have offline AIs to do that. But when a patient is sitting outside your clinic, you have these practical challenges when you do it in primary healthcare settings level or even in community healthcare settings. So we have to repair those cameras, recall those patients again, go to their home, sensitize them again to come back again, that this is not going to happen again, because that creates a negative influence within the villages. If you do call the patients and you don't do the screening and make them sit for 4 to 5 hours in these clinics outside. So that was resensitization and connecting with them again, so that this was a technical fault which will not happen again. Please come for the screening. So that is the connect you have to develop before implementing any digital health solution or any other health program. So these are some practical challenges that are going to happen. Thirdly, from the infrastructure point of view, trainings are very important. For example, for retinal image, that is critically important when you have to run it through AI. To detect microaneurysm, which is the first sign for diabetic retinopathy, if you have to screen that patient, you to detect that lesion, you need to have a good quality image, just like your photograph. You take it in your cameras to identify that, to identify a person right from 50 years ago, and having a camera which you have high-end cameras right now, you will easily identify those patients. One is optics. That is definite. That depends upon hardware and software. But the skill of the person who's going to operate that camera is very, very important. You give a high-end camera to a person who is not trained, the images are not going to work and your AI is going to fail. That happened with us also. So we entered the field, and the guys were trained at the Advanced Eye Center, but they didn't have the feel of handheld cameras at that point of time. They were trained on a portable camera. So portable cameras, you do not to do anything. You just have to make the contact with patient, ask them to sit, do all the ergonomics with the patient, make a contact, and take the imaging. But for the portable cameras, we tried that. And at that point of time, they were not trained to do that. So when they used that camera, 38% of the images were ungradable. So for an algorithm to work, you need to have good quality images first. Now, in case of ophthalmology, if you do diabetic retinopathy screening, ungradable images are also liable for referrals. Now, what if the patient didn't have anything that was an operator fault? He was referred to district hospital or maybe PGI. So that are over referrals. In garb of that, you'll lose the patients who actually needed referral at that point of time. So I'll tie back to the importance of training for that. So we called on the camera person for 15 days to work with us in the community health settings, in health and wellness center settings, and train our people to operate that camera properly, so that they take good quality images. So that significantly improved up to 15% from 38%, that ungradability. Otherwise, we were referring those patients. Then next, image quality, then referrals, then was, so again, infrastructure wise, for Dr. Anand was mentioning from Remedio, ungradability is a real issue. We have small pupil size in Indian population, so that's a fact. But to counter that, what we can do is we have suboptimal lighting conditions to capture images. But in PHC or health and wellness centers, you can imagine you cannot control the light conditions over there. So we created a optimized dark room by blackening all the walls within the health and wellness centers, putting thick curtains inside. By doing that simple intervention, the ungradability in next 1 month reduced to only 4%. So these are the practical challenges we never thought of while implementing AI solution. AI comes as a buzzword that we are going to increase the work turnover, we are going to refer those patients. So it all works, but we have to see the precursors as well, because we work in a public health system where you are not trained to do what you are trained to do in PGI, which is a tertiary care setting. Now, lastly, referral. So what after referral? You have to think about that. For example, we referred 68 patients, I roughly remember, and only 13 reached next health facilities. What about the others? So when we contacted them, certain socio-economic challenges also comes in, which I'll not touch up again, which are costing, geographical factors. I cannot go. I am dependent upon someone. So these are all factors which are quite known for other diseases as well. So for diabetic retinopathy, in a public health perspective, when you refer that patient, the treatment is only available at the level of tertiary healthcare facilities. You cannot expect that treatment to be at the level of district hospitals. You can have that, but you need to train the ophthalmologist. Ophthalmologist training need to be there, so that ophthalmologist has to go to tertiary healthcare settings to get trained. Then if he goes there, then who will look after the care of other patients who are there for who will be coming for next 15 days. So that's the training part of the training and treatment part. So in between, you don't know where the patient goes. So the funny thing and very unfortunate things happens in between when we interact with patients. Why you didn't go for treatment? So he said, आप मुझे disability certificate पे sign करके दे दीजिए, मुझे पेंशन लग जाएगी, मेरे लिए वही काफ़ी है. I am 65 now, I don't want my vision back. So these are very unfortunate things when we hear in the field. So I don't want to go to the next step for treatment. One is costing. Who will bear the costing? Who will take me there? Because diabetic retinopathy treatment needs several visits to get yourself treated and to see the vision outcomes, because it takes time for vision outcomes, for stabilizing your vision. So these are some practical challenges which I feel are very important and should be addressed and integrated while we implement any other digital solution, any other program, because we have to go to the ground root level, and there is no other way. You can work well in labs, but when you go into the primary healthcare settings, please take these things in mind when you are implementing or deploying your solutions in the field? Thank you.
Thank you. Thank you for highlighting especially those infrastructural challenges while we are deploying these solutions. Next, I'll turn over to last but not the least, Dr. Priyanka. Dr. Priyanka, you work on advising on various technical, clinical, and regulatory aspects for emerging technologies. I think it would be great if you could share from your experience the importance of design and inclusivity for AI design, development, and implementation, and what kind of approaches that you take to supporting health systems in this area.
Thank you for the question and good afternoon, everyone. It's a very, very important question. And considering that we have so many important stakeholders on the panel itself, I think the importance of design is not just at the level of responsibility of the innovator, but when we integrate these stakeholders in the systems approach, it comes down to something as simple as how do you co-develop, which, because I come primarily from the experience of medical technology and AI being integrated into that, I understand that AI in health can have different dimensions beyond that, but I can speak more from my experience. When you co-develop a solution, the inclusivity comes in terms of who is going to be your end user, how well you are understanding the capabilities, and looking at the training requirement, the systems requirement, the budget that would go into integrating that solution into the system. It also comes down to the model development, wherein inclusivity in terms of you can't have a model which is trained on US systems come to work in Indian systems. We've all discussed that. But even within the national level, at the regional level, at a population level, I can give you an example. We were working with a non-invasive testing device which used to read through the fingernails. And, looking at the integrity of, inclusion in terms of that population belonging to a labor class population and the thickness of the skin texture and the kind of reflectance that you would observe from the nail bed being integrated at the level of design would save so much of effort at the level of the innovator, but also at the level of health system, at the level of our time and effort that is being invested into that solution in being tested at the implementation stage where all the clinical validation, licensing and everything has been done. So AI is as an extension to that and as an integral part of a health technology cannot be seen as siloed. So it needs to be seen in a very comprehensive approach which looks at the usability from the healthcare workers' perspective, from programmatic perspective, or all the things which are at the level of infrastructure at the health facility, or whether this is about digital infrastructure. Power outages is one thing. Digital would also require a level of internet connectivity. If there is an offline capability, how do you make sure that the data is then sufficiently backed up, its quality assured. It's also to do with the acceptability, something we don't focus a lot. Acceptability in the communities, in the patient population that it goes to. So, you can have cultural differences. You can have very, very, minor cultural nuances, which you would probably not understand if you are just sitting in the lab or in your, office space and developing the tech. I remember one very interesting anecdote which we were testing for Path has a center of excellence for micro array patches, which are very, very fine micron size projections put in a form of an array, and this can be used for vaccine delivery, drug delivery. Something which is in development. We are hoping to have it come up first for the measles rubella vaccination scenario. But coming to the point, we were doing human factors evaluation for that technology, and in one of the African contexts, because the patch was supposed to be given on the wrist right here, the feedback that we got from the patient, it was a placebo sample, but the population level feedback was so interesting that it leaves a certain level of mark, which is approximately this kind of a size. And if that kind of mark is seen on a child, it's considered a taboo in the population. It's considered a sign of some devil being in the picture. So it's not tech, it's not AI, but it is something that is going to affect the adoption of the technology that comes in. So I think inclusivity, design, human-centered approach has to be taken care at all levels of these systems. And it also needs to be documented in a way that health systems can take an informed decision on how and what kind of technologies to be adopted and what are the other parameters that go to be able to sustain that adoption.
Great. Thank you. Thank you, Dr. Priyanka, for highlighting the aspect of human-centered design. Let me turn it over to the audience and see if there are any questions.
Hello everyone, thank you. I'm a doctor from JIPMER. I'm an MBBS doctor, and I've learned some Python coding also. I've worked on machine learning and AI models also. One of the things that I found, as Sir Dr. Tavpritesh said, is that we are focusing a lot on generative AI models, which require a lot of data, and that data is not present in India currently as of now. What we do have is the protocols that have been generated. So WHO protocols, IEP protocols and all. So one small project that I worked on was a pediatric hemodynamic digital twin. So when a dehydrated child comes to us, what are the different factors that we consider for that child? What is the calculations that are going on in our mind? Say if a child has malnutrition, then what are the risks, specific risks and specific different body parameters that have to be changed, and then accordingly we have to give fluids. And some of these things I coded it in Python. I modeled it in Python, algorithm, and finally it gave a prediction that for this child, if we give this much fluid, this will probably be the result you'll see in some time. There was no ML model in it, there was no AI in it. But when I went to the doctors, I'm myself a doctor, so one validation was from my side. But from other pediatricians, I found that they found this very useful. So I really want to know from you that things like micro system based modeling that we do, I'm not sure if this comes under computational biology per se, but I think systems like these, if we do it on, say, 1,000 different problem cases, then it will be a very big clinical decision support rather than a generative AI model which cannot be relied on. What are your thoughts on it and how we can work on it?
I think it's a great starting point. It's a fantastic example where you can start with a rule-based system. You have the clinical guidelines and you're using those as rules to guide decision making. It's a great starting point. And I think for many of the use cases that we have in reducing the workloads in the clinic, in providing decision support, these work perfectly well. Where it gets interesting is if you start using a combination of rule-based system and overlay with the data, right? That's where you can actually use a system which comes from prior knowledge, but then can also get trained with data. For example, why there are so many guidelines for antibiotic use. I work in the antimicrobial resistance space. Every hospital has its own guideline because there's context, right? So the context comes from experience of the physicians, of the local population that they're seeing. That has to be contextualized in the guidelines. Guidelines are very high level. You can contextualize those with data. That's where the power of AI can actually come in. But as you said, it's a perfectly good, valid starting point to build these kind of systems which can actually ease the work of clinicians. So great starting point.
So, sir, what additional ROI does that ML data for machine
learning? It may increase the accuracy. It may increase precision of the model, right? It may increase the positive predictive value of the model because we are looking, as I said, when you feed this rule-based system and overlay it with real-world data, it will learn something about that particular setting. It will be contextualized. That as a doctor, for example, you know that not now so much, but when I did my MBBS training, if you come from a certain eastern state, then you're seeing a patient with edema, you think about filariasis. If you are looking at a patient from northern part, you think about something else, maybe heart failure, kidney failure, right? So this is all context. So it's Bayesian thinking, right? So essentially, context will have to be overlaid upon rules, and some of these can actually be in at a later point of time be encoded as rules when you've learned enough. So the goal can be that to learn from data enough to get to the point where some of those can get encoded as rules, and then it's an iterative process when you can start building forward.
Yeah, so I had one question, Geeta here. So of course it's wonderful to hear the other side of the table kind of views, right? So I just wanted to sort of ask each one of you, like top two things, when an AI developer comes in with a technology that they want you to implement, what are the top two things that just one word or something like that across the table? Would love to hear the different perspectives. What's important, right? What are the top two criteria about the innovation that you would want to see?
We hold on to that, and we will end with that sort of response from the panelists. Maybe there's a question back here.
I think we need to always keep in mind who is the primary stakeholder. It is the end consumer. And my plight here in saying this is for him only. See, in such a gathering, we have elite people sitting on the stage, a good audience probably, and audience also probably contains another many panelists and speakers. So speakers speak, speakers listen, all right, and we go home happy. So the person who is treating, that is the primary health physician, he is not part of this meeting. The person who is going to be treated is the end consumer. He is not part of such a meeting. I think this is a very glaring gap. Unless we fill up this gap, nothing matters. All right. So I think I would like to have some inputs from that. How do we plan that we involve those people about whom we are really concerned? We talk hi-fi things, we talk of diagnostics, we go on to the community, but are we really reaching the community? So that is one thing. Second thing is, which I will say as a disclaimer, that the people who are going to use artificial intelligence, how well informed they are. Like I can take my own example as a disclaimer. I'm a medical professional, and if you ask me my qualifications, I'm very highly qualified. I've done my MBBS, I did my MD, I did my DM. All right, so that is the ultimate qualification. But when it comes to computers and it comes to AI, I think I may be something of primary level, 5th or 6th. All right. So who trains them? So I think let us realize that unless we convert the whole thing into a practical solution, that is training the primary care physician who is going to impart this thing, and then even consumer needs to be informed so that he knows where to go, how to go, what to do. हरियाणा गवर्नमेंट का एग्जांपल लूं एक आपके पास. हरियाणा गवर्नमेंट आजकल बड़ी फेमस है, हर चीज का पोर्टल है. But again, I'm an educated person. I don't know really how to use that portal. I go into that portal, either it doesn't work. If it works, I get stuck somewhere because I'm not fully knowledgeable about it. So what is the idea of having a portal? It's not helping the farmers. Farmers की फसल खराब हो गई है, उसको पोर्टल पर डालना है, उसको आता नहीं है. जिसको आता है उसको कॉम्पनसेशन मिल जाता है, जिसका नुकसान हुआ तो कुछ चवन्नी नहीं मिलती. Fine. So I think these are very important glaring gaps. Unless we fill them up, nothing is going to matter. So let us adopt the technology, but then high tech needs to be converted into high touch. If we can't have that high touch, then tech is no good. Thank you.
Thank you. Thank you, Dick.
Wouldn't you like? I mean, you have to respond to the.
We will go that.
Okay, Apu. I'm a student of political science, and I was very interested to hear all your perspectives. My question is, when it comes to our national healthcare policy, how do you deal with political or ideological challenges when it comes to our policy? For example, in the US, a lot of healthcare centers, a lot of doctors are very afraid to treat abortion patients because they have very restrictive laws. Or similarly, in India, when we had a public health crisis of COVID-19, a lot of the death toll numbers were somewhat underreported. And obviously, when you feed this kind of ideologically aligned data into your models, you're obviously going to come out with inputs that are very inaccurate to ground realities. So what would you recommend about how we change our national policy to accommodate for these? Thank you.
Great. Thank you, Sir.
Yeah. Good afternoon. I'm happy to see quite a few people on the stage. I'm Dr. Dhruv Chaudhary. I'm from PGI Rohtak. We are looking at it. I think what we are using today, AI, we are all using it. I come from critical care background, and it's the same question which Madam asked, primarily from the critical care. And we are using AI there, but we are using primarily as an enabler, not as a replacement. I think that's very fundamental, which we are using in a clinical medicine for decision making. So you are looking and talking in terms of generative AI, which I am also part of one of the projects of ICMR. We are trying to look in the radiology, how AI is going to ensure that we are not missing a single case of tuberculosis. So because it needs a huge database. And that's what we are realizing. We are doing around 45,000 plus X-rays to see and generate things which are there. What I am trying to look at it more, because we are also not only teaching, but also at the administrative side, how it can be enabler to us in a health system to ensure that it reaches to the bottom of it, where it matters the most. Everybody's talking about ASHA workers. They're so overloaded with the work. Now, the second thing which is coming up is now the gentleman sitting there and the lady sitting there is the CHOs. And we made one of the algorithms in ICMR, if you can recall, under the Dr. Bahel, is about CHOs. There are 12 different things coming from respiratory medicine only. So the question is, which I'm asking answer is that will they be, as he very rightly put it up, if you put a wrong thing, can you override it or not? I think these are the issues which are going to make a difference. I was quite impressed by the model which you talked about in terms of primary health care. It's basically a model which was practiced in UK. It's something like that USA, that, okay, we have 1,000 people with us. They pay us 700 rupees a month. So practically you have a targeted or nested population on which you are working. Am I right? If I understood it right. And then obviously you are working and you're looking after most of the primary things, and then you have do the referral, and the referrals, again, the layering is there in terms where to refer, how to refer, what to do. So there's a lot of these things which are coming up, and probably I think it's a beginning, it's not an end. So that's what I say. Professor Gupta himself has been a teacher for years and an administrator. That's why he was putting those points. So my point is, and my request to you is, when we are talking about it, probably we now realize it that the students in the medical schools who will be the end user of it, probably we need to integrate and talk much more. And that's what we did. We have 2 IIT young people came to us for lung cancer. We have a huge database. We converted that algorithm to COVID, and we used it for deciding the people who will come to the hospital. Because as a state nodal officer, I was looking at it, and trust me, out of that, we were able to pick every single thing by looking only 5 things: the heart rate, the respiratory rate, the saturation, and also the degree of breathlessness. And we were able to pick up, and we have presented that data, that it was nearly 90% positive predictive value. So it reduced our burdens. So I think that's sort of a help we need from the AI along with the precision medicine and precision diagnosis. Thank you very much for a long comment.
Thank you very much. Thank you. So I think, like you rightly said, there are panel members on this side, there are panel members on this side. So some we will take as comments and feedback, and we will definitely work on these as it's early on and evolving. But I would invite any of the panel members just to respond to any of the questions. Is there any? Yes, Sehj?
Thank you so much. I think a couple of you raised the point about, or at least how I'm interpreting, about does the end user, whether it's the physician, the CHO, or whoever is the end user, do they have the right, do they have the ability to override, do they have the ability to practice their own autonomy? I'll just give you an example. When we first started launching some of our clinical decision support, basically what we said was, look, this AI stuff is very slow, but it's important. So let's do this. Let's wait for the prescription to be generated. Then we will check against the protocols if everything is good or not. And so we rolled this out, and we asked the doctors as part of their we have a whole incentive framework and everything. We said, review the feedback of the system. And that feedback will let you know if there's any issue or something. And the reaction that we got was, are you kidding me? Like, you're judging my prescription and you don't know a thing about what I actually talk to the patient about. You don't know a thing about what we actually discuss. So it felt like judgment from the machine, right? And that judgment from the machine was the most counterproductive thing that we could do, because it was like, imagine having a medical student, over your shoulder and, looking at the prescription and saying, oh, you did that wrong. It doesn't know, right, what you've thought of, what you've spoken about, how you've reasoned and everything. So then we had to sort of switch to this model where, we said, okay, let's make it more real time. So thankfully, models had upgraded, had become faster and everything, where we were able to work with technology partners on the scribing side and all that, where we could capture literally everything that was happening and in real time start to expand differentials and do that. And to that, the reaction was, oh, now you're helping me. And to that, then there was more of warming up. Oh, you're helping me think better. But still, like, as I'm on the stage and all of that, there are alerts coming in every few minutes from the doctors saying this alert was not helpful for this reason, or this alert was actually useful, and I changed this practice. So you have to allow people to vote with their feet. So when we started using these technologies, there was a push in the organization. Let's mandate it. Let's require the doctors to adopt these sort of things. And on principle, we basically decided, no, nothing can be mandated on the technology side. It has to be adopted organically. And if it's not adopted, then it's failed. So I think this voting with your feet, voting with your voice is very important as we launch these. And I think being able to iterate it is also very important.
Great. Thank you. Yeah.
Yeah. So I have a point to make. I completely agree that AI has to complement decision-making support systems. For example, in our own work with auxiliary nurse midwives, it's not a standalone program. It can't be, right? I mean, we couldn't take off so we use Gen AI, of course, but the answer is given not just taken off from protocols overall that exist. We actually created protocols for ANMs that are very, very specific to that context, right? Because if you look at when you look at high-risk pregnancy management, there are protocols for high-risk pregnancy management for obstetricians, but it's very overall. It's not granular. It doesn't get into every use case that the ANM might face in the field. It's for the doctors to manage high-risk pregnancies. So what we did was to create protocols for every level of the health system. So the ANMs, the medical officers and specialists, very specific for every high-risk pregnancy that exists. Now and then we've trained them in it. And then we have a chatbot to support it. It cannot be a one-off chatbot that can be scaled up through the country without context. Because what works in Telangana will not work in Assam. So it's been really, really, so a lot of work has gone into creating those protocols. It's been vetted by health systems throughout the country. Every state we work with, we vetted with each level of the health system, from the nurses in the field to the doctors in the medical colleges. So it's been contextualized very thoroughly to the, context that we work in and the state that we work in. And now it's then been scaled up, right? So unless you do that, because the kind of question that come in, safety is a huge issue. Risk stratification is a huge issue, right? So, and you also always have to have a human in the loop, right? So it's very important that you keep validating the answers before you really know that it can be scaled up. Yeah. So.
Great. Thank you. Any other thoughts? Yes.
I think the point which was made about inclusion of primary care providers in convenings like this is very valid point. I think one thing is to be physically present here is something which is a point to be noted by the organizers in terms of how the design and all agenda is to be curated. But in terms of representation, if you look at it, I think what we all represent comes from our experience of working with these providers, with these communities, with these patient population. So it's not something which is just our voice, it's a collective voice. And why this is important is because it could not have been done in any other way. We can't sit here and just by our assumptions say that in a primary care system, this AI can have this advantage and this bottleneck unless we are informed. And this information comes not just by one-off touch points. There's also a method to it. I mean, as a public health organization, we follow mostly qualitative research patterns in identifying how these inferences are obtained and synthesized, sometimes in a semi-quantitative manner also, because that helps in defining the technologies forward. Where I think there is also an importance to highlight this is, it's something not to be done when the technology is ready and is to be introduced in the market. It's important that what you're saying is done at every stage, right? From ideation to prototyping to clinical benchmarking to operational validation and then implementation. It's a very, very valid point, and thank you for highlighting that. To your point, I think we all try to avoid the political aspects in public health, but I think I will not quote myself. I will quote this from a public health stakeholder, a government stakeholder. We were not underreporting COVID deaths. I mean, the reason that was quoted to us was there are a lot of advantages of reporting deaths in the country in terms of the kind of government benefits that you get from that. So it's important that the source of information from where you sort of understand that something like this is happening, sometimes even in the most reputed of the peer-reviewed journals, can be biased. So everything needs to be contextualized in the right light. We should be proud that India as a country is doing great when it comes to comparison with something like abortion laws in US. So it's something to be very proud of. And in my, say, probably a decade now of experience in the healthcare sector, I have not come across even a single case where the politics was the reason to not introduce a valid, required public health intervention. I would love to hear if there is anyone has had experience.
Yeah, I must second that, right? So I am an OBGYN who became a uro-gynecologist, and so I work in Sion Hospital, which is like a tertiary center in Mumbai for many, did my residency there. And our abortion laws are fantastic. And when the abortion laws came out in the US, and really, I mean, I must tell you this, right? So it's like the consent laws, right, for abortion, they're so, they give women agency, right? It doesn't exist in any other country, actually, to this extent. Because many other countries require validation from their spouses or from their family members. India has this one, it's the woman who can decide to come in and get an abortion done. So many of the very, interesting debate about healthcare, maybe because politicians don't care about healthcare, maybe, our policies are pretty, solid, like our constitution is. It's extremely, egalitarian and involves agency for the, patient and when I look at it from the, women's health perspective for the woman. Yeah, maybe it's
Dr. Aparna, the question is a little different. You see, nobody talking about abortion. This is again become contextualized. It's different from different. What he's saying, and I to partly do agree with it, is that at that point of time, the deaths were there. I was part of it. The system, I'm speaking from the horse's mouth, is that at that point of time, not in Haryana, but everywhere else, if you see, now you start looking at the data mortality which has come up. After 2 to 3 years, now we have upgraded, and you can see there is an increased number of deaths which were there. I was part of the Lancet Commission, and we did estimate at that time that the number of deaths was. So it's a political decision. So let's not discuss, this is not a forum. But yes, the Iraq's health is a politics issue, no doubt about it. It's a social issue, and that becomes quite controversial. So let's get out of it. The only thing which I am worried as a doctor, as a medical professional is, recently somebody wrote a prescription and somebody checked with an AI. They said, you have gone wrong, and they went to the court for the negligence. So I think somewhere we need to see how the AI is actually going to affect the practices and may not become the defensive practices as happened after the consumer law. I think that's something we need to be worried about this monster too.
Great. Thank you. I'm glad that the panel discussion has become a community discussion now. So with that, I think it's perfect time for break for lunch and continue with those discussions. And Dr. Sehj, I hope you're warming up now. So thank you, everybody. Thanks, a big thanks to all the panel members for their insights, their inputs.